I'm Bernard Gersh for European Heart Journal Today at Cardiology Update in Davos in Switzerland. And with me is Dr. Domenico Corrado, who's Professor of Cardiovascular Medicine at Padua and a national and international authority on sports medicine and particularly cardiological issues involving sportsmen. Domenico, could we just begin with a general question? What is the risk of sudden cardiac death in competitive athletes? I mean, we see the headlines in the newspapers and we see the numerator, but we don't see the denominator.
Sport activity is highly recommended by the medical community because it reduces cardiovascular morbidity and mortality. However, occasionally, vigorous sport activity can acutely increase the risk of arrhythmic sudden death in susceptible individuals. A prospective clinical pathologic study performed in the northeastern Italy, Veneto region of Italy, demonstrated that in adolescent and young adults, sport activity increases the risk of sudden cardiac death by 3 times. In other words, to perform competitive sport activity increase the risk to suddenly 3 times in competitive athletes.
On competitors?
Competitive athletes. What is important is that it's not the sport in itself that increases mortality. Sports acts as a trigger of ventricular fibrillation and sudden arrhythmic death in those individuals, in those athletes affected by cardiovascular disorder predisposing to arrhythmic cardiac arrest.
In the United States, it's clearly hypertrophic cardiomyopathy is the top of the list. And actually, the area I live in Minnesota, where there's a lot of ice hockey, commotio cordis has been implicated as a cause. But in Italy, number one is arrhythmogenic right ventricular dysplasia.
Yeah, generally, cardiomyopathy are the leading causes of sudden cardiac death in young people. We deal with inherited heart muscle disorder, hypertrophic cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy that account for 1/3, 2/3 of mortalities rates during sport activity in young people.
Now, in your really interesting talk that you gave today, and I realize you can't go into detail, but you made a very interesting observation in terms of current recommendations. And you pointed out that these are not based upon scientific evidence, but it's a consensus document, really, much as things were with hypertrophic cardiomyopathy until 3-4 years ago when we first developed guidelines.
Yeah, the available recommendation documents come from the United States, the so-called Bethesda Conference, and from Europe, the European Society of Cardiology recommendation for eligibility for competitive sport activity in athletes with cardiovascular disorder. Both recommendation documents are mostly based on expert consensus, based on the personal experience of panelists, rather than on data, scientific data supporting this recommendation. So accordingly, the current recommendation should be regarded as a prudent suggesting recommendation from experts concerning the risk of...
So could I ask you just if you could give me maybe your top 5 diseases that are an absolute contraindication to competitive sport?
Yeah,
where there's no doubt.
We'll learn from a retrospective study on sudden cardiac death victims, because unfortunately we don't have prospective studies on are that cardiomyopathy, inherited cardiovascular disorder, that means hypertrophic cardiomyopathy, right, first of all, followed by arrhythmogenic right ventricular cardiomyopathy, and ion channel disorders, yeah, that are an inherited condition that are characterized by predisposition to ventricular fibrillation in the absence of structural heart disease, namely long QT syndrome, Brugada syndrome, or short QT syndrome are the most important condition.
Asymptomatic Brugada's, what do you recommend?
Asymptomatic?
Asymptomatic Brugada syndrome. Yeah,
asymptomatic Brugada syndrome is a challenge, of course, because we don't have data about the long-term outcome of, especially in athletes,
yeah, and
because apparently,
QT either.
Yeah, apparently the risk to die suddenly increases. During night at rest in Brugada syndrome rather than during competition or during exercise. But you have also to consider that the functional adaptation of the heart of the heart implies a vagal hypertone that in itself increases the risk to die suddenly for athletes.
That really is a very gray area, isn't it? Tell me, if you could just help me, a clinical scenario that I find quite commonly is I see an individual with hypertrophic cardiomyopathy, young man or woman, and I say, no competitive sport, period. And then they say, okay, fine, I'm not going to play college sport or university sport, but what can I do? And what is the definition of competitive sport? I mean, I used to play tennis with someone on a Sunday, and this was like going to war. This was, and so what I've always said is, you can do anything you want as long as you can have a conversation with the person. If you're riding your bike or you're running or jogging, that's okay.
That is a very, very important point. We can consider non-eligible individuals affected by hypertrophic cardiomyopathy for competitive sport activity, but they can perform other kind of sport, leisure time sport activity at the same intensity of competitive sport activity, so they remain at risk to die suddenly. So it's extremely important to make aware the patient of the risk to die suddenly, and probably in young individuals you are also at risk. You have also to consider beta blockers therapy, to as an additional measure, anti-adrenergic measure to prevent sudden arrhythmic death in a sport.
I must say I do treadmills also on all of them, and look at what happens with their rate response to exercise. You did mention that there are differences across the Atlantic in terms of the rules for disqualification. Could you just elaborate a bit on that?
Bethesda Conference and European Society of Cardiology recommendation provide different disqualification approaches in many cardiovascular areas. Generally, European Society of Cardiology recommendations are more restrictive than the US recommendation, and this reflects probably the different cultural, social, medical, legal backgrounds across the ocean.
It's interesting, isn't it? Because some people would say they'd expect America, which is a more litigious society, to be more restrictive. But in fact, it's not.
I think that probably the reason is that the European Society of Cardiology recommendation mostly reflect the Italian medical legal background. In Italy, there is a systematic pre-participation screening, and athletes, of course, should be considered eligible according to the specific guidelines that are extremely restrictive.
Very interesting. Let me ask you, just to wrap up, where do we go from here? A future perspective.
Yeah, I think that the current recommendation document should be revised. The review should provide, first of all, more evidence-based recommendation. We need scientific data in order to provide.
I'll just interrupt and ask you, the current document should be revised for both sides of the Atlantic. I don't really think we need a different set of disqualification regulations.
Yeah. I think we should have a shared document in order to have,
sports a global phenomenon.
It's a global phenomenon. There is no reason that across the ocean we have two different management strategies.
Is this actually in process?
Yeah, we are working with the U.S. sport medicine societies and the European Society of Cardiology.
And when can we expect that to be published?
We hope to provide a document by the end of this year.
Oh, that's great. Well, thank you for your talk today, and thank you for this interview, for joining us.
Thank you very much.